I'd like to invite Dr. Mohammad Asha to speak about metabolic syndrome risk stratification. He's a senior consultant in internal medicine specializing in obesity, metabolic disorders, and sleep medicine. The floor is yours, Dr. Mohammed.
Shukran. Assalamu alaikum, and thank you so much for inviting me to this lovely country. Today, I will try my best to change our vision from the old school of metabolic syndrome and how we can implement this into a real life and clinical approach. These are my disclaimers and disclosure. Our learning objectives for today to understand metabolic syndrome as risk stratification rather than a disease entity by itself. Try to apply the American Heart Association 2023 for the CKM staging, CKM, CRM interchangeably. Um, Implement multi-systemic risk assessment across cardiovascular, renal, hepatic, and inflammatory domains. Utilize the evidence-based pharmacotherapy such as SGLT2 inhibitors or GLP-1 receptor agonists in the cardiorenal protection. And finally, to develop a practical workflow for early detection and intervention for patients before they develop irreversible organ damage. Why metabolic syndrome matters? Because around 33% of the US adults, they meet the criteria of metabolic syndrome. It increased the risk of cardiovascular disease by 2 times and the risk of diabetes by 5 times. All the tools that we have for screening of uh, um, heart disease or metabolic syndrome, they usually underestimates the risk of metabolic syndrome, such as the Framingham score, which usually misses the subclinical disease burden, the Q-risk score, and the 10-year cardiovascular risk score. We need a multi-system assessment beyond glucose and lipid control, and we need an early intervention window that is usually missed. Over the years, the evolution and definitions of metabolic syndrome since 2001, we had the NCAP-ATB3, which was a widely adopted criteria and mainly focused on abdominal obesity. The IDF 2005 focused mainly on ethnic groups and required central obesity. And the one that we are currently using is the harmonized 2009, which I will discuss in the next slide. The harmonized is made of 5 pillars. The waist circumference more than 102 centimeter in men and more than 88 centimeter for females. Triglyceride of more than 150 milligram per deciliter. HDL level of less than 40 milligram per deciliter for men and less than 50 for females. Blood pressure of more than or equal 130 over 85 and fasting blood sugar of more than 100 milligram per deciliter. So any patients with 3 or more of these 5 pillars will be considered as a metabolic syndrome. So what's next? The revolutionary CKM that was adopted and developed by the American Heart Association 2023 and was subclassified into 5 stages would help us further stratify these patients according to their risk, follow-up prognostic factors, and treatment plans. I'll go through the stages one by one. Stage 1 CKM is defined as no excess adiposity, no metabolic risk factors, normal kidney function, and no established cardiovascular disease. CKM stage 1 is excess adiposity, where a patient has a BMI of more than or equal to 25 and increased waist circumference, with visceral adiposity or ectopic fat, and no other metabolic risk factors. Stage 2, or the metabolic syndrome by the harmonized, is a metabolic syndrome component where a patient has a prediabetes or diabetes, they have hypertension or dyslipidemia. And here where we transition for stage 3, where we have early end organ damage. So in stage 3 CKM, patients start having certain abnormalities in their labs, albuminuria of more than 30 milligram per gram, EGFR starts dropping from 60 to 90 ml per minute, calcium scoring of more than 100, left ventricular hypertrophy or diastolic dysfunction. Stage 4 is the clinical cardiovascular disease, and these patients are already established heart disease or end organ damage. They have established cardiovascular disease, heart failure, advanced chronic kidney disease, or coexisting CKM risk factors. And here where the time is too late for reversing, and we start thinking about secondary prevention rather than primary prevention. So why do we need this staging at this point? Because it carries a prognostic precision, better cardiovascular disease risk prediction than the traditional calculators alone, which usually miss albuminuria, for example. It gives us a clear guidance of which medications we have to start on. We have limits, we have thresholds, and we have a follow-up interval that we need to follow. And we can track the progression of disease or organ damage evolution over time. From there, so we understand now the CKM staging. So what we need to do, other than taking the history, do the physical examination, what are the four main things that we have to include in our risk assessment for these patients? Number one is the first domain is the cardiovascular risk. And here we have to look into two different areas. One of them is the atherosclerotic disease, and number two is heart failure. So for atherosclerotic disease, we have to think about certain investigations such as the calcium scoring. When should we implement this? Who are the patients that we want to go with lipid panel beyond the total cholesterol, LDL, HDL, and triglyceride, and include more of the ApoB and lipoprotein A? Who are the patients that would benefit from ankle brachial index, and what are the heart failure with preserved ejection fraction risk markers that we have to look for. For the calcium scoring, the patients that we would like to ask them to go beyond blood test and do more non-invasive imaging are patients who have a 10-year cardiovascular risk of 7.5 and above, especially if these patients are resisting statin medications, patients with metabolic syndrome and two more components. We're talking about stage 2 CKM, patients with strong family history. And the interpretation should go as follows. If the calcium score is 0, then these patients are low risk, 1 to 99 are moderate risk, 100 to 400 are high risk, and more than 400 is very high risk. So if the patient, for example, gets a calcium score of more than 100, they have to be started on statin regardless of their LDL level. And the aspirin use is based on a shared decision making upon other risk factors. What about other markers of the lipid panel, such as the ApoB? Usually these patients carries high risk, and for patients with CKM stage 2 or 3, it can be done routinely, and your target would be less than 80 milligram per deciliter rather than choosing LDL alone. Non-HDL cholesterol less than 130 and would capture the remnant lipoproteins. LPA is usually done once in life at least, and especially for those patients who have a family history of premature coronary artery disease, it's wise to look into this number, and your target will be less than 50 milligram per deciliter. Other measures that we can use for the patients who are presenting to our clinics and doing assessment for metabolic syndrome or CKM is to do the ankle brachial index. So barely we do this anymore, but it's very important to look into other atherosclerotic disease other than the coronary artery disease. And the ABI is less than 0.9. This points toward peripheral arterial disease. And if it's more than 1.4, that means an advanced arterial stiffness disease. Consider always also carotid ultrasound for patients with a very high risk, and think about escalating your treatment based on the outcomes. Second pillar of the cardiovascular assessment is the heart function. Heart failure with preserved ejection fraction usually goes missed because patients might have no symptoms. And when do we have to think about assessing for such a thing? Is when patients they have obesity, and especially a BMI above 35, patients with long-term diabetes of more than 10 years, patients with uncontrolled hypertension or coexisting obstructive sleep apnea. What tools do we have to perform in order to rule out heart failure with preserved ejection fraction? We can choose between pro-BMP, or the better is send the patient to the cardiologist for an echocardiogram. The second important domain in our assessment or clinical assessment when we receive a patient with suspected metabolic syndrome is the renal risk. And here we have to look into two numbers. Number one is creatinine or EGFR, and number two is the albumin-creatinine ratio. The kidney disease improving global outcomes have updated the chronic kidney disease assessment. On the right table, you can see that we are not only looking at the creatinine, but we have to combine it with the proteinuria level, and the lower the creatinine and the higher protein, the worse are the outcomes. Why albuminuria is important? Because it carries an independent vascular injury and independent cardiovascular risk. Albumin-creatinine ratio of more than 30 would lead to endothelial dysfunction, increase the cardiovascular disease, and by itself is an indication of CKM stage 3. Domain number 3, and here Dr. Naji spoke about it in more details. I will just go briefly on it. And here we have to look into three levels. We have to recognize what is called muscle or MASH. We have to implement the FIB4 index and screening for every patient with metabolic syndrome. And whenever indicated, we have to send the patient for fibroscan. And the interpretation, again, we do the calculation, which is very simple. If the patient has FIB4 less than 1.3, they have a low risk. Between 1.3 and 2.67, they have intermediate, and more than 2.67, they have high risk. And around 60 to 70% of metabolic syndrome patients, they have already some sort of muscle, and around 5 to 10% of these people, they have advanced fibrosis. Fibroscan, in much details, it's indicated in people with metabolic syndrome, and they have other indications away from metabolic syndrome. But for our focus here, for our patients, usually patients with type 2 diabetes, BMI of more than 25, elevated FIB4 or persistent ALT elevation over ALT over AST elevation. However, fibroscan comes with some contraindications for patients with ascites or acute hepatitis, patients with congestive hepatopathy, or patients who are with very high BMI, where the probe can give us either false positive or false negative results. So risk stratification by liver stiffness. Again, Dr. Naji talked on this with details, but the patient, briefly, if they have a result of less than 8 kilopascal, they are considered as low risk, and they can be followed with the primary physicians with routine monitoring. Between 8 and 12, they have more than F2, and it's better to be referred to a hepatologist for further assessment. And the higher the number, the more the complication, until we reach KPA more than 15, where liver cirrhosis starts developing, and there are a multidisciplinary team care at this level. Why liver disease is important in our assessment? Because liver disease or muffled is a hepatic inflammation, which increases the systemic insulin resistance, which in turn increases the risk of diabetes. Dyslipidemia is amplified in patients with muffled, and that increases the atherogenic burden on the coronary arteries, which will lead to more cardiovascular mortality. The last domain that we have to look into in our assessment is the sleep, whether it's an obstructive sleep apnea or other sleep disorders, such as insomnia, other circadian rhythm sleep disorders, anxiety, and so on, which are usually forgotten in our assessment. As simple as a screening called stop bang would give us a hint if the patient needs further assessment or not. For example, obstructive sleep apnea accounts for around 70% of people with metabolic syndrome, and it carries a very high risk in cardiovascular disease, also on cognitive function and the quality of life, which will all eventually lead to either cardiovascular disease or refractory hypertension. And the mechanism behind this is usually due to intermittent hypoxia, which leads to sympathetic activation, endothelial dysfunction, glucose dysregulation. And this is the stop bank questionnaire. 8 questions that can be asked in less than 30 seconds. We can ask the patient if they snore loudly, if they feel tired during the daytime, excessive daytime sleepiness, if they have either observed apnea or witnessed apnea, if they are diagnosed with hypertension, if their BMI is above 35, if they are more than 50, if the neck circumference is more than 40, and if they are male. So, few questions that could help us stratify the risk of sleep apnea. And if the patient collected 3 or more points, and each one of these gets 1 point, by the way, they would need to be evaluated for obstructive sleep apnea. One final domain that also can be helpful is the testing for high sensitive CRP. High sensitive CRP is considered another independent risk for atherosclerotic cardiovascular disease, and high sensitive CRP of more than 2 usually considers statin even if the LDL is normal or borderline. However, we have to bear in mind that the patient, they don't have inflammation, they don't have infection before ordering such a test. Overall, how we can integrate this into our risk assessment. For stage 2 and beyond, the patient should go beyond doing lipid panel, HbA1c, ALT, AST, CBC, and so on. We have to think about digging deeper into our organs. If they have stage 2 and beyond, think about calcium scoring based on the indication I mentioned earlier. For every patient coming with metabolic syndrome, obesity, not necessarily diabetes, not only we need creatinine, but always albumin creatinine ratio. Implement the FIB4 screening test for all of your patients presenting to your metabolic clinic. Think about sleep as an independent risk factor for heart disease, and sometimes patients who are undiagnosed or untreated for sleep apnea or they have insomnia, usually they show resistance for medication. So whenever we ask why our patient is not responding, we usually forget about this. How can we translate this into our daily practice? For a patient who has stage 0 to 1, we would keep encouraging the patient to continue what they are doing with lifestyle optimization and primary prevention focus. For stage 2, we have to do further investigations and do our risk stratification and implement some pharmacological treatment. Stage 3, we have to be very aggressive. Maybe we can reverse what they have. However, in stage 4, all we can do is secondary prevention. We hope we don't get there. Lifestyle interventions, what can be asked the patient to do? 150 minutes of exercise weekly. This is very optimistic. We don't want to tell the patient do 150. This is the optimal, I know, but usually ask them to do as much as they can. Just give them some habitual changes that would make them more active rather than stick to an exercise. In stage 2, we need to be more aggressive with 5 to 10% weight reduction. In stage 3 and 4, we need more than that. We need at least 10% of weight reduction. Statin therapy, who are the patients who need statin therapy? We need to consider it for every patient with a CKM stage 2 with LDL above 100 or ApoB above 100. CKM stage 3, they have to be initiated on statin regardless of their LDL level. And patients with CKM stage 4, we need to target an LDL of less than 55 milligram per deciliter. When to initiate RAS blockage? This is for the kidney and the heart, for patients with hypertension, for patients with proteinuria, reduced EGFR, patients with left ventricular dysfunction or left ventricular hypertrophy, and of course for patients with heart failure with preserved ejection fraction. SGLT2 inhibitors for patients with type 2 diabetes or established or high risk for atherosclerotic cardiovascular disease, heart failure, either reduced or preserved ejection fraction, chronic kidney disease with albuminuria. So, and finally, for GLP-1 receptor agonists, if our aim is weight loss, for cardiovascular protection, we have to choose one that is approved for cardiovascular protection. MASH improvement, they can play a big role. And finally, for the kidney benefits and reducing albuminuria. These are the FDA approved or known GLP-1s with cardiovascular protection, liraglutide, semaglutide, and dulaglutide so far. How can we combine these medication all together? Statin and RAS blocker for patients with stage 2, if they have hypertension. If a patient has diabetes or chronic kidney disease with proteinuria, always think about SGLT2 inhibitor. If the patient has high cardiovascular burden and obesity, GLP-1 receptor antagonist. And according to the rest of your results, whether they have a high calcium score or they have a positive treadmill test, you can think about adding either aspirin, and if the patient does not respond to proteinuria after a while of optimizing RAS inhibitors or SGLT2 inhibitor, you can think of finerenone as an add-on therapy if there is no contraindication. This is a summary of the approach. This is everything I just mentioned. So how do we monitor our patients? According to each stage, for stage 0 and 1, all patients above the age of 40, they should be followed annually with weight, blood pressure, lipid, glucose, in addition to history and physical examination. In stage 2, we need to see the patient every 6 months, and we have to optimize their lifestyle. In stage 3, the interval becomes less, and we have to see them every 3 months, and we have to ensure their compliance on medication, follow up on their labs, and see how we can intensify it, because this is the last level before we get an end organ damage. And in stage 4, we have to do an intensive monitoring as part of a multidisciplinary team approach. So the take-home message, metabolic syndrome is not a disease. It's an early warning system. It signals a stratification risk and intervene before irreversible organ damage. It identifies the patients who need comprehensive vascular, renal, and hepatic assessment. Number 2, CKM staging is a clinical compass. Stage 0 to 4 integrates metabolic, kidney, cardiovascular risk into a unified framework. Stage dictate intensity of lifestyle intervention, pharmacotherapy, thresholds, and monitoring frequency. Metabolic syndrome maps to stage 2. Organ damage begins at stage 3. So the only difference between stage 2 and stage 3 is the organ damage. So when we start having albuminuria and so on. Number 3, risk stratification must be multisystemic. We have to think always about the 4 domains: the cardiovascular, renal, hepatic, sleep disorders. Our glucose-centric approach misses critical organ damage driving mortality, so it's not only about sugar. Number 4, early pharmacotherapy saves organ. As we always say, the earlier the better. Don't give too much chances. Usually patients, they don't follow. So start with the SGLT2 inhibitor and GLP-1 with providing cardiovascular and renal protection beyond glucose lowering. If your patient is obese, offer them GLP-1. If they have even mild proteinuria, offer them SGLT2 inhibitor. Evidence supports the use in CKM stage 3 and 4 even without diabetes. And the combination of cardiorenal metabolic therapy is for high-risk patients. Practical implementation. First, you have to go for the harmonized 2009 criteria. Ask about the 5 pillars. Does the patient have metabolic syndrome? If yes, implement the CKM criteria. Check on their body weight, adiposity, hypertension, diabetes. Check for end organ damage. Number 3, check for end organ damage in cardiovascular, renal, hepatic. Escalate treatment and intensify based on their risk factors, either every 6 months, 3 months, or 1 year, and monitor with stage appropriate frequency. With that, then thank you so much.